871 in medic 6. You're seeing a 74-year-old male, shortness of breath.
Capnography is the fastest method for providers to evaluate and identify changes in patient condition. It provides a graphic picture and an objective measure of a patient's ventilatory status. Capnography allows for identification of changes in patient condition faster than any other monitoring device available.
Capnography is the measurement of exhaled carbon dioxide in the breath. We're able to monitor that carbon dioxide exhalation through either the hub of the ET port or from the mouth or nose in a non-intubated patient.
Most responders are familiar with using capnography for reliably identifying endotracheal tube placement and rapidly identifying endotracheal tube displacement. However, many responders only intubate 8 to 10 times a year or less, depending on the responder's service area and the number of providers in their EMS system. Capnography can also be used to enhance the assessment of non-intubated patients. By providing responders with immediate information about a patient's condition as it progresses or changes, capnography can help direct providers to the most effective treatment. Because it measures carbon dioxide exhalation, capnography is an excellent tool for measuring the effectiveness of chest compressions or signaling the return of spontaneous circulation.
Capnography can be used in any situation when we want to identify the patient's metabolism, perfusion, or ventilatory status. Most commonly for me, I use capnography in any patient I give narcotics to maintain and to watch their ventilatory effort. I'm also using it in someone that has an altered mental state, anyone that I'm suspecting some respiratory difficulty, and then of course all of my intubated patients.
Any change in capnography waveforms can be traced to one or a combination of three things: metabolism, perfusion, and ventilation. During metabolism, the body metabolizes sugar and oxygen to produce energy. A byproduct of this process is carbon dioxide, or CO2. As metabolism rates increase or decrease, so does carbon dioxide production. If metabolism increases from exercise, such as when the body works harder to compensate for an illness, capnography can measure the higher respiratory rate and increased carbon dioxide that is exhaled. Perfusion is the flow of blood through the body. Blood must circulate through the body to adequately remove carbon dioxide. As blood flow drops, the ability to return carbon dioxide to the lungs is decreased. A decreased level of carbon dioxide is indicated on a waveform by a number lower than the normal range, while carbon dioxide partial pressure, or PCO2, levels remain normal or lower than the normal range. A patient with low blood pressure will have abnormally low numeric values while maintaining a normal waveform. Ventilation is the movement of air into or out of the lungs. The body regulates respiratory rate via chemoreceptors in the blood vessels that read carbon dioxide partial pressure levels. As PCO2 levels rise, the body increases the respiratory rate to blow off the excess.
If I overventilate myself on purpose and I'm breathing fast, obviously then I'm blowing off that CO2 at a greater rate than which my body is producing it. So when we look at ventilation specific with capnography, if we have someone who's breathing at a respiratory rate of 30 or 40 and they have an end tidal between that 35 to 45 range, we know that respiratory rate is compensatory for some increased metabolic production.
By using capnography, a responder can quickly identify when a patient's metabolism, perfusion, or ventilation may be signaling a serious condition. Reading a capnography waveform requires looking at both the height and length of the waveform. The height of the waveform shows the amount of carbon dioxide. The length of the waveform depicts the time of exhalation. A capnography waveform has 4 phases. Phase 1 occurs during the exhalation of air from the anatomic dead space, which normally contains no CO2. The monitor reads from 3% to 100%. This part of the curve is normally flat, providing a steady baseline. Phase 2 occurs during alveolar washout and recruitment, with a mixture of dead space and alveolar air being exhaled. Phase 2 normally consists of a steep upward slope. This represents the rapid mixture of alveolar and dead airspace gases. Phase 3 is the alveolar plateau, with expired gas coming from the alveoli. This is the most important part of the waveform because it represents good alveolar lung functioning. In patients with normal respiratory mechanics, this portion of the curve is flat, with a gentle upward slope. The highest point on the slope of Phase 3 represents the end tidal carbon dioxide value. Phase 4 occurs during inspiration, or when a patient takes in air. The end tidal carbon dioxide level normally drops rapidly to 0. This part of the waveform is a steep downward slope.
The important parts of that waveform are Phase 2 and Phase 3. 1 and 4 come into play, but they are secondary. So when I'm identifying a waveform, the first place I look at is Phase 2. Is that sharp and steep? Then I look at the alveolar plateau. Is that flat? Does it have a slight rise? From there, then I look at my respiratory rate and my numeric value to determine whether this is a normal end tidal waveform or not.
The main purpose of using capnography is to identify lung function during exhalation. Therefore, phases 2 and 3 are the most important to the interpretation of the waveform, while phases 1 and 4 are secondary. EMS responders need to understand the variations in capnography waveforms, both normal and abnormal. Because most responders do not use capnography on a frequent basis, they may be limited in their understanding of abnormal readings.
There are a lot of things that can change that waveform. Some things aren't a big deal, other things are. In order to understand what abnormal is, we first must know what normal.
The normal waveform should be square or box-like in appearance. The normal range of CO2 in exhaled air is 35 to 45 millimeters of mercury. The respiratory rate would be within normal limits. Abnormal waveforms will display a gradual increase in end-tidal carbon dioxide, which appears as the rising peak at phase 3 of each wave. These abnormal waveforms are associated with rising body temperature, hypoventilation, and increased metabolism. Common abnormal waveforms EMS responders will encounter include hypoventilation, hyperventilation, and bronchoconstriction. Typically, the hypoventilation waveform appears square like a normal waveform, only with prolonged exhalation. The range is greater than 45 millimeters of mercury. Hypoventilation can also have a very small waveform in shape and value if the patient is not producing adequate tidal volume for the monitor to read. The hyperventilation waveform is typically square in appearance with a shortened exhalation phase. The numeric value is less than 35 millimeters of mercury. The characteristic waveform pattern for bronchoconstriction is a shark fin shape. When bronchospasm hampers ventilation, there is a curved upstroke of phase 2 with a more pronounced angle to phase 3. Again, there is a prolonged exhalation phase. Capnography is very effective for determining if treatment on a non-intubated patient has been effective.
When I first started using it in capnography, I put it on every patient. Did every patient need capnography? No, but I put it on so I could start to identify changes that I was seeing and what was concerning and what wasn't concerning. As I progressed then, I started to modify the patients that I used it on in cases that I really wanted to identify those 3 key issues: metabolism, perfusion, or ventilation.
Capnography can also be useful in the objective assessment of respiratory complaints or for treating pathologies that involve air trapping, such as asthma, chronic obstructive pulmonary disease, and anaphylaxis. Because capnography can provide information on how effectively carbon dioxide is being produced by cellular metabolism, EMS responders can more effectively assess a patient's metabolic status. Capnography is also an excellent tool for determining metabolic acidosis and can be used in trending the treatment of patients with diabetes. Responders can utilize capnography to assess and monitor a patient's response to the treatment of pain. Patients in significant pain will often have shallow, rapid respirations that can be seen via the capnograph as a small and tachypnic waveform. Capnography has a host of other applications. It can identify and warn providers of oversedation from a narcotic by signaling hypoventilation, or indicate apnea with visual and audible alerts. Following a patient's seizure, EMS responders can use capnography to identify adequate ventilatory effort. EMS providers should watch for a return of spontaneous circulation in patients in cardiopulmonary arrest by looking for a rise in both the capnography waveform and the number. This can often happen before a palpable pulse can be felt. Waveform numeric changes can take up to 12 hours to normalize. EMS responders should not expect a rapid change back to normal numbers, but should continue to monitor the waveform shape for changes. Changes in the waveform shape will most often display before the patient starts to feel better, allowing EMS responders to more quickly determine whether the treatment is successful.
If we see the waveform change, or we see that as numeric values get either on the high or the low side of it, what we have to be aware of is the body's inability to compensate for changes that are happening within the body. So as a real quick, easy way to measure metabolism, perfusion, and ventilatory status in our patients, we can use the non-intubated capnography to identify that we have a normal respiratory rate and that we have an end tidal between 35 to 45 with a normal appearing waveform.
Deep breath. Looks like things are improving here. Are you feeling any better?
Yeah.
Okay. Okay. You feel like that medicine's helping? Good.
So it's important for the provider to remember that any change in capnography can be traced back to either a change in metabolism, perfusion, or ventilation. The challenge for the provider is to figure out which one, two, or all three of those things has come into play.
Although it does have an increased cost, the frequent use of capnography is justified by its effectiveness. It can help to decrease the number of unidentified conditions and decrease the possibility of incorrect or incomplete treatment. By using capnography more often, EMS responders can gain proficiency in its use and help to provide the best patient care possible.